Yeah, my lecture is going to be on current status and future perspective in minimal invasive mitral valve surgery, and also on red lines. And I think concerning the presence and also the future, we have to discriminate between different realities. One reality is the cutting edge technology and technique in the leading hospitals, which is definitely different from the average and also from teaching hospitals. So I come from an environment of a university hospital, which is a teaching hospital, of course, and we had the challenge to find a way in between the most advanced surgical technique and also the reality we are faced with to train our young surgeons. So the presence is different. Concerning the future, it's very similar. We have other challenges, except from technology, which has still to be developed to improve access to the mitral valve concerning imaging. We have very good devices nowadays, 3D, but there's still a lot of room for improvement. We also have, concerning technology, the challenge to develop better instruments, surgical instruments. On the other hand, we have the necessity of training, and we have the necessity of acceptance in the surgical community. And I personally know several surgeons who have abandoned a minimal invasive approach due to some negative results, and that has to be overcome. So I think concerning training and the future, it is necessary to make a stepwise approach, and in an institution which has not a very high caseload, this specific type of cardiac surgery, the invitation and the support of a proctor is mandatory. Otherwise, there are, from patient side, there are also red tapes which cannot be passed because not every pathology concerning the mitral valve is suitable for a minimal invasive or endoscopic approach. For instance, if there is severe analog calcification, or if there are other conditions concerning calcifications of major vessels. And as I already mentioned, also from the surgeon side, there may be contraindications, because if the surgeon still simply doesn't have the caseload to become really proficient with this technology, the surgeon, he or she, should stick to another minimal invasive technique, which is not endoscopic, but for instance, partial sternotomy, which is still much less invasive than a full sternotomy.